radiologist here at Creighton University Medical Center. We're going to do a brief discussion of epidural hematomas, and so we'll start with a case. So before us here, we have an axial image from a non-contrast head CT, and there are arrows pointing to a hyperdense extraaxial collection that has a lens shape or football shape or biconvex morphology, and it's overlying the right temporal lobe, and it's resulting in some mass effect on the right temporal lobe. You can see that there's a little bit of compression of the temporal horn of the right lateral ventricle. There's some localized sulcal effacement here. Probably not much shift midline. We can see the suprasellar cistern and the quadrigeminal plate cistern are patent. So biconvex, extraaxial, hyperdense collection. So this is a classic epidural hematoma. They all tend to have this morphology, at least in the traditional sense. Now, there is a differential diagnosis for extraaxial collections in general, and that's what you see here. Subdural hematomas can be hyperdense and extraaxial, but they have different morphology. You can have an infectious collection, such as an empyema in the epidural space that could have this morphology. The density would be different. You can have neoplasms that are extraaxial that could conceivably simulate this appearance. And then extramedullary hematopoiesis, which is kind of a exotic, strange imaging finding, but good to keep in mind in this setting. So let's talk about epidural hematomas. And in this sense, I just want to qualify here that we're talking about the classic arterial epidural hematoma. There are several classifications of other types of epidural hematomas that we probably won't get into in this short lecture series, but these are the classic biconvex extraaxial hemorrhages that are seen in a clinical setting of trauma. That's what we're discussing here. So biconvex is the descriptive buzzword that you want to use for these, or lens shaped, and they are within the epidural space, right? Which means they're actually positioned between the skull and the dura mater. These tend to be hyperdense when they present acutely, but about a third of them can have mixed attenuation, which is what this diagram is showing here. So this is a predominantly hyperdense biconvex extraaxial collection, but there are some elements of lower attenuation. Now, the significance of that, as this is called the low density swirl sign, and that can suggest that there's actually active bleeding with unrestricted clot in this collection, and that's a poor prognostic sign. So these are almost always associated with a skull fracture. You can see our schematic shows the skull fracture here. As a rule, these collections typically do not cross sutures. There are exceptions to that. When we have venous epidurals, that's a completely different classification of collections that we probably won't talk much about in this particular lecture. And they can cross sutures if there's injury to the suture, right? Either diastasis or a fracture. So here's the rules about epidural hematomas. They nearly all occur at the Ku site. They're almost always arterial. They're almost always adjacent to a skull fracture. They tend to be unilateral, and they tend to be supratentorial, meaning involving the compartment of the dura that involves the cerebral hemispheres rather than the cerebellum. And so the majority of these within the supratentorial compartment are in the temporoparietal region, although they can also occur in the frontal and parietal occipital regions. So here's just another nice example of an epidural hematoma. You'll see this is a larger one than the one we looked at before. This maintains that biconvex morphology that's classic for arterial epidural hematomas. You might even suggest that there's a little bit of low density within this to suggest some active bleeding or unrestricted clot. This collection is resulting in a lot of mass effect on the right cerebral hemisphere. There's actually sulcal effacement within both cerebral hemispheres. There's effacement of the right lateral ventricle, and there's also midline shift. You can see the subfalcine herniation here. Also on the bone window from the same plane of section, you can see that there's a mildly depressed comminuted skull fracture, which classically goes along with these epidurals. So clinically, when patients end up with this particular injury, in half of the cases they have this classic clinical scenario in which they have the inciting traumatic head injury. They have what they call a lucid interval. So the patient suffers a trauma and initially has loss of consciousness. And then they have a subsequent asymptomatic time between the loss of consciousness and the onset of symptoms related to the mass effect. So this classic lucid interval occurs at about 50% rate in these particular injuries. What happens is these can get delayed development and enlargement within the first 36 hours. Because these are arterial bleeds and because they tend to get larger in the first 36 hours, the management of these is surgical. So almost all of these are surgically evacuated if they are of any size at all, because they can get very big very fast and the patients can run into trouble really quickly. So when they're very small, less than a centimeter in diameter, they can be managed conservatively. These are the people that are in the ICU getting neurochecks, getting serial head CTs to keep an eye on these collections. So the outcome from these particular injuries is very good if they're promptly recognized and treated. If they're not, the outcome is very, very poor. Thanks for your attention.